So somebody wanted to know a little bit about herniation syndromes of the brain. And basically when you have your brain and brainstem, you've got rigid constructs here that are going to serve as mass lesions. So if you have high pressure, it'll press on the rigid structure, and the thing that's rigid in your brain is the dura. So the brain itself is kind of soft and squishy, and if you push a soft and squishy thing against a hard thing, you'll get neurologic deficit. So in the midline, we've got the falx, and at the break point between the supratentorial and the infratentorial region, we got the tentorium. So these are rigid structures. And so for neuro-ophthalmologists, what we're looking for is when we have a patient who has papilledema or evidence for increased intracranial pressure, whether that's from a mass lesion or obstructive hydrocephalus or whatever the cause is, we have to worry that this might be an emergency because we don't want the brain to herniate. So that herniation can occur transfalcine, which will cause mass affected shift of the brain, or it can be transtentorial herniation, and the thing that's going to herniate down is called the uncus. So the uncus can go down here, and the thing that's going to be compressed is the third nerve. And so for a neuro-ophthalmologist, what we're worried about is uncal herniation producing a third nerve. This notch in the tentorium is called the Kernahan notch, and so this is sometimes referred to as the Kernahan notch phenomenon. That's why in the neurosurgical ICU, they don't really allow you to put dilating drops in the person because they're looking for this blown pupil as a sign clinically of herniation. So we don't put dilating drops in the neurosurgical ICU patients. So when we're looking for uncal herniation, this is what we call a false localizing sign. So a localizing sign tells us where the problem is. It's localizing. A true localizing sign tells us exactly where the problem is. A non-localizing sign doesn't tell us where the lesion is. And so the best example is a sixth nerve palsy from increased or decreased intracranial pressure. That is non-localizing. That doesn't tell you where the lesion is. Likewise, papilledema doesn't tell you where the lesion is. It seems like it should be in the eye because the nerve is swollen, but papilledema and non-localizing sixth are non-localizing findings of increased or decreased intracranial pressure for sixth, increased intracranial pressure for papilledema. In the Kernahan notch phenomenon, it's a false localizing sign, which means not only does it not tell you where the lesion is, it might tell you you're on the wrong side. Or it might even be supratentorial and not really down here in the infratentorial area. So for example, if you have a hemorrhage or a mass on the left side of your brain, that could lead to uncal herniation, that could push the uncus down, but the third nerve up. The third nerve on the right could get compressed from the displacement of the brain. And so someone who has a right pupil-involved third nerve palsy could have a left intraparenchymal frontal lobe hemorrhage. So not only is it not in the posterior fossa, it's in the brain. Not only is the lesion not on the right, it's on the left. This is a false localizing sign of brainstem herniation, the uncal herniation, the Kernahan notch phenomenon. In addition, if it's going down the foramen magnum, we get the Chiari malformation. So Chiaris are also a herniation, but not of the uncus, of the cerebellar tonsils. So we've got tonsillar herniation, we got brain herniation, we got uncal herniation. You need to know a little bit about the herniation syndromes in neuro-op.